Howdy, y'all. I'm Dr. Jeff Jarvis, and I have some exciting news. I think some of y'all have heard that there is an opportunity for us to get involved in some prospective research, some research that is going to help us understand how to best treat our patients with pain from trauma. And we have made some exciting progress. We are going through the final stages of approval with JPS and with THR Fort Worth, so our big two trauma centers, and we're going to participate in a randomized control trial, that's an RCT, where we give patients with trauma and pain either fentanyl or ketamine. Now, this is the same thing that we're doing at your discretion right now, but the truth is we don't have great evidence that tells us which one of those two drugs is better for different types of trauma patients. And the only way we can really find that out is by a randomized control trial. We have the opportunity here in Fort Worth to participate in that. This is much like some of the stuff, if you've been around for a while, when we participated in the ROCK trial, like intubation versus the King LT, same concept here. I have on the video with us today Jonathan Jenkins. Jonathan is a paramedic who works for the University of Pittsburgh, and he is the education manager for the LIGHTS Network, and he's going to tell us a little bit about this study. Jonathan, thank you very much for joining us.
Thanks, Dr. Jarvis. Thanks for having me. I appreciate it. It's great to be here.
Absolutely. It's always a pleasure to talk to you. Jonathan, you have a shirt on that says LIGHTS. That's the network that you're in. Anytime we talk about acronyms, I always like to know what the acronym stands for. What does the LIGHTS network stand for? And then tell us what the whole point of it is and who's paying for it. That's always helpful.
Yeah, right. Because you can't do research without a cool acronym, right? It's like
exactly.
A prerequisite. So as you mentioned, my name is Jonathan Jenkins. I work for the University of Pittsburgh, and in their School of Medicine, they have, through the Department of Surgery and the Department of Emergency Medicine, they have a research network called the LIGHTS Network. And LIGHTS stands for Linking Investigations in Trauma and Emergency Services. And it came to be a little over 10 years ago. This is actually 2026. We're entering into the 10th year of LIGHTS. So the Department of Defense has provided funding for the LIGHTS Network to answer research questions and conduct clinical trials for trauma and EMS resuscitation care. Not all of the trials that they do are EMS-centric, but most of them are. All of them revolve around trauma care. And now fast forward to today, 10 years later, don't quote me on these numbers specifically, but it's about 75 trauma centers in the United States, as well as a few in Canada, about 100 or so EMS systems, and about 10 or 12,000 EMS clinicians that have worked to answer some of these questions. And LIGHTS has done work on various different things over the last 10 years. They've done a lot of work in the space that is whole blood and different blood products, so whole blood versus component therapy for transfusion. They've done some work. We had a trial just finish called the PACT trial, which was the pre-hospital airway control trial that is trying to answer the question of what is the best airway management methodology in trauma patients. It was much like the PART trial that looked at cardiac arrest. This is looking at trauma. We've done some other work in the space that is calcium for hemorrhagic shock patients. That's a trial that is going on right now as well. And then this trial that we're going to talk about that involves Fort Worth is what's called the PAIN trial, and that stands for the Pre-Hospital Analgesia and Intervention Trial, which is a randomized controlled trial that's going to try to seek the answer to the question of what is the most optimal way to manage pain in trauma patients, and not just trauma patients generically, but specific populations of trauma patients.
Yeah, I like it. So when I am talking about a research study, I like to describe it according to a formula. The formula is discuss the methods, the population, the intervention, the control, and the outcome. So the methods, we said this is a randomized control trial. It's also what's called a double-blind randomized control trial, which means the patients don't know which of the two drugs they're getting. But you also, as the paramedic, don't know which of the drugs you're getting. We'll talk all about the logistics and stuff on how to do this coming up. But essentially, there's a syringe, and it just has a number on it. You can't tell which of the two syringes is which, because that's an important bias, and we're controlling for the bias. So that's the methods. The population is who we enroll in the trial. So that's defined by the inclusion and exclusion criteria. Well, Jonathan, can you tell us who we're including and who we're excluding in this study?
Yeah, absolutely. So the main population of patients that we're going to look at for this study are patients that have suffered a traumatic injury, that are in pain, that are in compensated shock. Going to JPS or Harris, they have to have a pain score of 5 or greater on the standard 0 to 10, how bad's your pain, numeric scale. And they have to have some vital sign criteria. So the vital sign criteria is either a shock index of 0.9 or greater, and remember that is heart rate divided by systolic blood pressure, or just a heart rate of 115 or greater.
All right. So now there is some issue here about gender or sex. So men are in. What's up with women? Because I hear you folks in the Lights Network don't care about women.
Yeah. So to enroll a patient, any male patient over 18 is acceptable. So remember the 3 Ps of research, right? We don't enroll pediatrics. We don't enroll prisoners. And we can't enroll pregnant females. So for this study, potentially pregnant means that we can't enroll females that are less than 50 years old. And the reason for that really is an abundance of caution from the FDA with this medication. Because it is a blinded drug, there is a 50% chance that they'll get fentanyl or ketamine, and it's just an abundance of caution for maternal fetal health. So when we come to write the paper, when this study's over, a limitation of this study will undoubtedly be that there's a large subset of patients that we weren't able to look at.
You bet. That's the inclusion-exclusion criteria. Next up in our PICO framework is intervention and control. And we already said the intervention or the control, these are interchangeable, is fentanyl, and it's 100 mics of fentanyl. Or ketamine, which is 0.3 milligrams per kilogram of ketamine, same dose we use here. One thing that is different is right now we give a bolus of fentanyl and an infusion of ketamine. Well, you would know whether you're giving an infusion or a bolus, and that sort of defeats the point of blinding. So it will either be 100 mics of fentanyl or 0.3 per kilo of ketamine as a bolus. And then if that doesn't relieve their pain, they still meet the inclusion, they can get a second dose. And then it's up to you, manage their pain per our existing protocol. That's what is the primary outcome we're looking for? And then what are some of the secondary outcomes?
Yeah, absolutely. So the primary outcome for this study is 24-hour mortality. But we're going to look at some other things as well. So, was there a reduction not only in their pain, but was there a change in their hemodynamics with one medication versus the other? We're also going to look at how many days did these patients spend in the hospital post-injury, and of those days, were they in the ICU? Was there a need for them to be ventilated at some point or another? Did they have any sort of generic adverse events, right? Episodes of hypotension, hypoxia, the normal H-bomby type things that we often talk about, and then the need for additional doses of that pain medicine post initial injury, insult, and medication.
Perfect. So if you're worried about this being difficult to remember, don't worry. We're going to do additional training. We're going to have memory aids, some checklists, some just reminders all over the place. We'll continue to work on that. So the Lights Network has IRB, Institutional Review Board. That's the ethics board that has reviewed the study and has approved it with DOD influence, with FDA. All of those people have had a say and said, yes, this is reasonable to move forward. But then we also need to have local IRB approval. And as it turns out, THR Fort Worth and JPS use different IRBs, so we'll be getting IRB approval from them. The main thing we wanted to do here is just let you know this is coming, give you some information, some background information about it, introduce you to Jonathan. Jonathan is going to be helping us do training on this process. Very exciting. We have an opportunity here in Fort Worth to help guide the future of trauma care. Y'all know that we benefit greatly from research that has been done in other places, and I look at this as our opportunity to pay this forward and contribute on our own to what is guiding medicine. So very excited about that. Jonathan, thank you very much, and I look forward to working with you again.
Yeah, thanks for having me, and looking forward to getting to know everybody down in Fort Worth and getting this study off the ground here in the coming months.
We're going to have to take you down to the stockyards, get you a pair of really nice boots when you're down here. You gotta fancy up Pittsburgh, man.
I can't think of anything that the people in my life would enjoy more than seeing me in a pair of fancy boots, so I'm in.
That was a great statement because I have no clue what that means, but I'm not going to press you on it. I'll take a one where I can get it. Guys, thank y'all for joining us. As always, thank you for what you do. Take care.